This is the fourth video for Unit 2. This is the acid-base portion of the content. I'm going to talk about acid-base balance. Acid-base balance is reflective of how alkaline, basic, the body fluids are, or acidic. It's expressed as pH, and normal pH balance is 7.34 to 7.35 to 7.45. It doesn't take the body very long to be out of balance before we have some big issues. The body just doesn't function very well out of balance. So there's several ways that the body compensates for this to try to get the body back in acid-base balance. There are chemical buffers that the body uses. Bicarbonate, HCO3, which is a basic, it's a base, it's alkaline. Carbonic acid, H2CO3, phosphates. So there's ways that body compensates for this out of balance. All right, there's two ways that the body compensates: the lungs and the kidneys. The lungs adjust breathing. So breathing can speed up, it can slow down, it can become shallow or deep in order to adjust the CO2 level in the body. CO2 is an acid. Normal CO2 level is 35 to 45 millimeters of mercury. The other way the body regulates acid-base balance is through the kidneys. The kidneys do this by reabsorbing or excreting bicarbonate. Normal bicarbonate level is 22 to 26 milliequivalents per liter. Lungs can adjust the breathing very quickly. This can happen within a few minutes. The body senses things are out of balance and it can adjust breathing very, very rapidly. The kidneys, on the other hand, take longer. It's usually several days before it can adjust the reabsorption level to make a difference of the bicarbonate. All right, so we're going to come back to this PowerPoint. So I want you to go on. We're going to talk about acidosis, alkalosis, and we're going to talk about metabolic and respiratory acidosis, metabolic and respiratory alkalosis. All right, metabolic acidosis. There's too much acid, hydrogen, in the body. Can be caused by several things. Kidney disease, they can't hold on to bicarbonate, so they build up acid in their system. Too much exercise in a short amount of time and not excreting those excess acids from the byproduct of the breakdown of the muscle. But the most typical cause you're going to see for metabolic acidosis is diabetic ketoacidosis. So what happens when someone's diabetic, they've got a high glucose level. The glucose levels in the blood are high. The cells don't have any energy. So the cells are starving even though the glucose levels are high because there's no way for the body to get it into the cells. So because the cells are starving, they're going to do whatever they need to do to survive. What they're going to do is start breaking down muscle and fat. Byproduct is lactic acid. So this is probably the most typical cause of metabolic acidosis that you're going to see. pH goes down. It's less than 7.35. Now the body doesn't usually run very well, function very well when their pH is low. I think the lowest pH that I've seen somebody survive was 6.6. Usually anything below 6.9 is usually fatal. So let's talk about what your patient's going to look like, and then we're going to talk about some specific interventions. All right, so here's your picture for metabolic acidosis. All right, so the first thing that you have to know about acidosis in general, any kind of acidosis, is that acid causes vasodilation, which means it relaxes blood vessels, so there's less pressure in the blood vessels. So this is going to drive a lot of the symptoms that you see. All right, if you look at on the left-hand side, they typically have a headache. That makes sense because they have vasodilation of the blood vessels in their head, so they've got increased intracranial pressure. Their blood pressure goes down, vasodilation. What's going to happen to the heart rate when blood pressure goes down? It's going to go up. So their blood pressure is going to be down, heart rate's going to go up. Let's skip down. It says warm flesh skin. That makes sense. All the blood vessels are vasodilating, including the capillary beds. All right, let's go back up to the hyperkalemia. So why would they have an elevation in their potassium levels? Acid causes disruption of the cellular membrane. So the cell membrane ruptures and dumps all the intracellular potassium into their blood system. So their potassium levels go up. So what's your patient look like with high potassium? This is where it all starts to fit together. Everything speeds up, gets all twitchy. The muscle twitching makes sense. The nausea, vomiting, further down the list right there makes sense because their GI system, everything's all sped up. On the right-hand side, they have a change in muscle tone, change in their reflexes, change in mental status. That all fits with high potassium. All right, so let's talk about breathing. If metabolic cause is driving the acidosis, diabetic ketoacidosis, something like that, if the metabolic is a cause, the lungs are okay. There's nothing wrong with the lungs, so they can compensate. Remember the compensatory mechanism. The lungs can compensate by breathing. What they do is they become rapid, deep breathing. Kussmaul breathing is the term for that. It's rapid and it's deep. And the purpose of that is so that the body can get rid of an acid, CO2, to get the pH back into balance. All right? Breathing's not the problem. This is a response to what's going on. All right? So it's compensatory hyperventilation, rapid deep breathing, trying to get rid of some sort of acid to get the pH back into balance. All right? So what are we going to do for this person? Well, we're going to treat the cause. If elevated glucose levels is the cause, diabetic ketoacidosis, what are we going to do? We're going to give them insulin, and we're going to give them fluids, get their blood pressure up. All right. If they've got high potassium, all those things that we talked about for high potassium, those interventions would apply. If insulin is taking glucose back into the cells, then the potassium level will go down. We're treating the cause. If they're breathing rapid and deep, think about how dried out their mouth might be. They're probably going to want their head up just for comfort. Now remember, breathing is not the issue here. This is a metabolic acidosis issue. Blood pressure's low, so they're probably going to have orthostatic blood pressure. If their blood pressure's low, what would happen to the kidneys? Probably decrease urine output to hold on to fluid. Think about renin-angiotensin aldosterone and think about ADH. Output would go down. Safety, level of consciousness, those are all things that we would do for somebody who has metabolic acidosis. All right, we're still talking about respiratory or acidosis, but now it's a respiratory cause. The problem is the breathing. They have an increased CO2 level. Something's happened. This is a gas exchange issue. Okay, so I want you to cross off hypoventilation and put gas exchange. Typical cause would be someone who has pneumonia, somebody who has chronic lung disease. We'll talk about COPD in Unit 6. All right, so let's go on to and look and see what your patient's going to look like with respiratory acidosis. All right, so breathing is the problem. There's something that's affecting gas exchange. They don't have enough oxygen, they have too much CO2. And again, I want you to cross off hypoventilation and I want you to put a gas exchange issue, which leads to hypoxia, low oxygen levels. All right, if somebody has low oxygen levels, what are they going to look like? Rapid, shallow breathing. Something's wrong with their breathing, so they're going to be fast breathing. This is shallow. This is not the rapid, deep like Kussmaul breathing. All right. Acidosis, it's still vasodilation because of the acidosis. So you're going to see some of the same symptoms as the other one. low blood pressure, high heart rate. They're going to have a headache. They're going to have the same issues with high potassium because it's acidosis. Okay, same changes in mental status. Now, key in on the difference. Their skin with respiratory acidosis, remember it's hypoxia, their skin is pale and cyanotic. They don't have enough oxygen. They got too much CO2 and not enough oxygen. All right. Both metabolic and respiratory acidosis could have arrhythmias related to potassium issues. This is also an issue for respiratory acidosis because now we have an oxygen issue, and the cardiac muscle doesn't respond well to low oxygen levels, and then you add that to the high potassium. All right, changes in muscle strength, changes in mental status. All right, so what are you going to do for this person? Well, gas exchange is your primary concern. So you're going to raise the head of the bed because that automatically improves tidal volume, better diaphragmatic excursion, less gravity on the chest. Cough and deep breathe. They've got secretions, pneumonia. We want to do those things to thin those secretions. Increase fluid intake. We talked about that in Unit 1. Orthostatic blood pressure, the same as metabolic acidosis. Those safety things. The issues with high potassium. They're probably going to have vomiting or diarrhea and nausea. All right, we're going to treat the cause of whatever is causing the gas exchange issue. And we'll talk about specific things for treatment, medications, those kinds of things in Unit 6. All right, so we've talked about acidosis, metabolic cause, and respiratory cause. Now let's flip it. We're going to talk about alkalosis. Don't have enough hydrogen ions or an increase in bicarbonates, which is a base. Okay, pH is low, that's acidosis. pH is high, that's alkalosis. All right, typical causes are someone who's had prolonged vomiting or a GI illness. And if you think about all the hydrogen ions that are normally in the GI tract, this person has gotten rid of all their excess hydrogen ions and now they don't have enough. So that's a pretty typical cause. All right, so the picture of your person with metabolic alkalosis. Note the color. Now, they are not actually this color of green, but it's to drive home the point that they've probably been vomiting, and so you feel kind of pale and kind of green around the gills when you've been vomiting all the time. All right, so if acidosis ruptures cell membranes, causes increases in potassium, alkalosis forces potassium back in the cell, so their overall potassium levels go down. So now you have hypokalemia. All right, same issue with arrhythmias related to the potassium level. Change in mental status. Think about your person with low potassium. All right. Changes in muscle strength, nausea, vomiting. Now with the alkalosis imbalances, you also have an issue with low calcium. So now low calcium and low potassium, the symptoms look kind of different. So that's why you're going to see a variation of what you see because it's a combination of low potassium and low calcium. All right, so let's talk about the breathing. Compensatory hypoventilation. All right, this person has alkalosis because of a metabolic cause. They've been throwing up or they've had all the hydrogen ions out of the GI tract removed. All right, the quickest way the body can affect overall pH is by breathing. So if they don't have enough acid, what's going to be the response of the lungs? They're going to slow down breathing in order to retain CO2 and acid to affect the overall pH to get it back in balance. All right, so they could have low breathing, not effective breathing, rate will slow, depth will decrease. All right, now I want you to think about your patient's symptoms from hypokalemia. What's our primary concern? It's slowing down breathing. And now you have metabolic alkalosis, which also has the effect on slowing down breathing. So this person is at risk for respiratory arrest, which means they will stop breathing. So this is a primary concern for even though it's a metabolic cause, because of the way the body compensates for the low potassium and the basic environment is by slowing down, they could potentially stop breathing. All right, so what are you going to do for this person? We got to treat the cause, number one. What's the number one way that you can affect breathing? Is putting the head of the bed up. Hopefully they get better tidal volume, better lung expansion. They're at risk for atelectasis. Right? Do all those things you're going to do for somebody who has low potassium. So you need to go back and look at that. If they've got arrhythmias, cardiac monitoring, mental status, they're at risk for safety issues. If they've got low calcium on top of that, they're at risk for seizures, all those things that we talked about with low calcium. All right, continuing alkalosis. Now the alkalosis is caused by a respiratory issue. They don't have enough CO2. All right, this could be due to hyperventilation. This could be due to anxiety, panic attack. Somebody who has a temperature that's breathing really fast, the body's way of trying to cool off. All those things could typically cause a decrease in overall CO2. Probably the most common one you're going to see is somebody who has a panic attack or is hyperventilating. So what's your patient look like that has respiratory alkalosis? All right, so hyperventilation, again, breathing is the cause of this. And they've started into this loop in their brain where they start hyperventilating, and they just can't stop on their own. It's very, very difficult. Their brain's kind of in this loop. All right. If you think about tachycardia, their heart's working really hard trying to keep up with their breathing. Blood pressure might be affected because it's alkalosis. Still the same issues with low potassium, so muscle weakness. They could have some paresthesias, numbness and tingling of the extremities. Same issues because it's alkalosis, low calcium, changes in their reflexes, increased anxiety. If it's not addressed, one of two things will happen: that they finally just kind of be able to relax and stop on their own, or it escalates to the point where they pass out or they have a seizure, which is not good. So what are we going to do to intervene for that? So number one thing, we're going to put the head of the bed up because they feel like they're short of breath and they can't breathe. Now it's not addressing what's going on, it's just a pure comfort. All right, low stimulus environment. Make sure it's quiet. Talk to them in a calm voice. Maybe coach their breathing, breathe along with them as long as you don't hyperventilate along with them. Medications are like a last resort. And then typical treatment for respiratory alkalosis is you have somebody breathe into a paper bag. So how does that work? What happens is that they are rebreathing CO2, which is an acid, which then their pH starts to go down into normal range, and their accelerated breathing gets better. All right, so some more lab values that you have to know. You need to know normal pH, you need to know CO2, you need to know bicarbonate. You need to be able to figure out, if I give you a pH, a CO2, and bicarbonate, which state it is. Is it metabolic or respiratory, acidosis, alkalosis? So the next couple of slides are doing just that. So you look at if it affects the CO2, it's a respiratory issue. If it affects the bicarbonate, it's a metabolic issue. All right, so let's look at some numbers. Here's a set of numbers, pH of 7.51, CO2 of 25, bicarbonate of 22. All right, so first thing you do is look at the pH. pH is 7.51. What's your normal pH? 7.35 to 7.45. So it is high. It's alkaline. All right, so we know it's alkalosis. Let's look at the next one, CO2 of 25. What's a normal CO2? CO2 is 35 to 45 millimeters of mercury. Okay, so that's low. Bicarbonate, normal bicarbonate is 22 to 26. This is 22, so that's normal. So if something's normal, cross it off the list. So we've got a high pH, a low CO2. CO2 is an acid, remember. So we have respiratory, CO2 is low. Alkalosis, pH is 7.51. Let's look at the next one. All right, pH is 7.21. CO2 is 39. Bicarbonate is 15. So let's look at our numbers. pH is 7.21 is low. It's acid. It's acidic. So we know it's acidosis. So let's figure out what kind of acidosis it is. All right, the CO2 is 39. Normal CO2 is 35 to 45. That's right in the middle, so that is normal. So it's not CO2 that's the issue. All right, bicarbonate is 15. Normal bicarbonate is 22 to 26. That's low, so that makes sense. So it is a metabolic acidosis. So here's just a couple of more diagrams to look at. So go to that acid-base mnemonic handout. That was one of the first slides at the beginning of the PowerPoints. There's a handout that's posted on Talon as well. I know you've been shown multiple ways how to figure out whether it's acidosis, alkalosis, metabolic, respiratory. I don't care how you do it as long as you can get the correct answer. I like the ROAM acronym. That seems to work the best for me. Students seem to understand that, but if you have a different way of doing it and you can get the correct answer, that's fine. There's some practice problems that are posted on Talon. We'll probably do some of those in class just to make sure that everybody's good for doing that. Acid base, the Venn diagrams also work very well for this. So make a Venn diagram for acidosis and put metabolic and respiratory on either side. Compare them. They share common symptoms. Those common things are great, but focus on those things that indicate whether it's respiratory or metabolic, if it's acidosis or alkalosis. And that concludes the PowerPoints for the acid-base portion.